Okay, so we now move to the part 2 of our discussion. So this one is for the bipolar disorders na. So I hope you did have a good break. Okay, so mahabang discussion na naman to. So with the first one, we have the bipolar 1 disorder. So bakit siya bipolar 1? So there is an alteration between major depressive episodes and manic episodes. So bipolar 1 yun ha. Major depressive and mania ang nakikita dito. Whereas with bipolar 2 disorder, this is an alternations between major depressive and hypomanic episodes. So, this was discussed in part 1, the difference between the mania and hypomania, as well as the symptoms of major depressive episode. And then, when we say it's cyclothymic disorder, ayan naman, it's an alternations between less severe depressive and hypomanic period. So, again, di ba nga, na-mention ko na ang counterpart niya is dysthymia or persistent depressive disorder. Pero sa bipolar, for the group of bipolar disorder, it's cyclothymia or cyclothymic disorder wherein there is a less severe depressive uh, periods and hypomanic periods. So, unahin muna natin si bipolar 2. Okay. With the bipolar 2 disorder, the criteria have been met for at least one hypomanic episode and at least one major depressive episode. So, for this one, again, the criteria are identical to those of a manic episode. So, there should be a minimum duration of 4 days. Although the episode represents a definite change in functioning, it is not severe enough to cause a marked impairment or hospitalization. So again, the presentation of the symptoms is less severe or less less severe than mania. And usually for hypomania, there are no psychotic features, whereas with manic um, or bipolar 2, if there is presence of psychotic features, sometimes it's expected. Although hindi naman lahat ng cases ay may psychotic features. And of course, there should have never been a manic episode. Okay? And C, it shouldn't be explained by other types of disorder, particularly those under schizophrenia spectrum disorder, as well as major, no, delusional disorder. Okay. Okay, the symptoms of depression or unpredictability caused by frequent alternations between periods of depression and hypomania causes clinically significant distress and impairment in social, occupational, and other important areas of functioning. So, just like always. And then you also have to specify if uh, if the episode is current or recent in a hypomanic episode or current or recent in a major depressive episode. Again, this is to help the doctor or the practitioner with better case management. And then you also have to specify if there is anxiety or anxious distress or if it's with mixed features or if it's rapid cycling or mood congruent psychotic features, mood incongruent psychotic features. So, another different set of specifiers na naman to. So, again, it would be very good or it would be great if you would open up your DSM-5 and DSM-5-TR and look at what does it mean with these specifiers. Kasi, pag inisa-isa ko yan dito sa discussion na to, it's really going to eat up time and baka baka hindi na tayo matapos sa chapter na to. Alright. Now, with the cyclothymic disorder, this is the more chronic version of a bipolar disorder. So, this alternates between periods of mild depressive symptoms and mild hypomanic uh, symptoms, and the episodes do not meet a full criteria of major depressive episode, a full hypomanic episode, or a full manic episode. Hypomanic or the depressive states may persist for long periods, so just like with the persistent depressive, yun nga lang, again, may hypomania ditong in, included, kaya it's not persistent depressive disorder. And it must last for 2 years, 1 year for children and adolescents. Okay. So, tingnan natin yung sa diagnostic criteria. So, for at least 2 years, there must have been a numerous periods with hypomanic symptoms that do not meet the criteria for a full hypomanic episode, and numerous periods with depressive symptoms that do not meet the criteria of a major depressive episode. During the above 2-year period, the hypomanic and depressive episodes must have been present for at least half of the time, and the individual has not been without symptoms for more than 2 months at a time. So again, yun nga, hindi siya po pwedeng walang symptom for 2 consecutive months. Otherwise, it's not cyclothymic disorder. Baka iba yon. And criteria for major depressive, manic, or hypomanic episode have never been met. Next, the symptoms in criterion A are not better explained by schizoaffective disorder. Again, these are all schizophrenia spectrum disorder. And the symptoms are not attributable to psychological effects of a substance like drug abuse and other medical condition. Okay, so andito naman tayo sa specifiers. So please look at it carefully. Okay. So the specifiers, all the specifiers for the depressive disorder may also apply to the bipolar disorder. Again, parehas lang yan. Separate lang sila for better understanding of the disorders. Kaya much better na tingnan nyo or aralin nyo mabuti yung mga specifiers na to. Kasi usually maraming ganyan sa depressive and bipolar disorders. Okay. So, additional unique specifier to bipolar disorder is the rapid cycling specifier. So, the rapid cycling specifier, ito yung mabilis siyang alternate between mania and depression. And then, the individual experiences at least 4 manic or depressive episodes within a year, and this type of specifier usually occurs between 20 to 50% of the cases. Now, I cannot stress this enough. One of the reasons why we have to put in the specifier, kasi nga, it helps with the case management, and like with this one, the rapid cycling specifier is associated with greater severity. So, to help with better case management, mas magandang aware tayo sa mga specifiers na to at inalalagay natin siya sa case. Okay. Now, with the prevalence of the disorder, mood disorder, there is a worldwide lifetime prevalence of MDD at 16%. And about 6% have experienced major depression in the last year. This is pre-COVID statistics, ha. So, likely tumaas yan ngayon since 2019 to 2022. Wala pa akong statistics for that. Pero, definitely nagtaasan ang stats for this particular disorder. And then, in terms of the difference in sex, females are likely to have twice as likely to have major depression. Um, Although, in terms of bipolar disorder, ang nakikita nila is that it equally affects males and female. In terms of major depression, may nabasa akong study about that. Ang assumption nung nagsulat is that mas mataas kasi yung likelihood na i-report siya ng mga female patients than males. Kaya mas mataas ang statistics for depression ng babae kaysa sa lalaki. And then, in terms of the specifier, ayan, women are more likely to experience the rapid cycling specifier and also the depressive period. So, I guess it also has something to do with the difference and the biological makeup. And then, in terms of pre-pubertal children or children in adolescence or preteens, it's less often that they would be diagnosed with this disorder. Although pagdating ng adolescent years, doon na tumataas yung number ng nadadiagnose with this type of disorders. And then adults over 65 years old have about 50% less prevalence than the general population. This is because they have other, or they tend to experience other disorders like yung somatic disorder and also anxiety disorder. Yun yung mas na experience nila or mas mataas yung prevalence sa kanila. Okay, in terms of statistics, bipolar is the same in childhood, adolescents, and adults. Prevalence of depression is also seen to be similar across subculture. So, walang difference sa mga minority, the minority population in terms of the display or exhibit of the symptoms of depression. Okay, now this one. So, before studying, or before this, the more advanced studies in the field of abnormal psychology, the thought is that hindi magkakaroon ng depression yung mga bata. However, studies have shown and clinical findings have shown that 3-month-old babies can show already depressive symptoms. So, diba? Very surprising. Although, young children don't typically show classic mania or bipolar symptoms. Kaya nga, sa kanila to very rare na i-diagnose to sa kanila. And then, kaya rin nilagay yung disruptive mood dysregulation disorder kasi it's the practitioners in the field thought that it's more appropriate diagnosis for them than the bipolar. And then at times, because of the similarities in the symptom, the mood disorder might be misdiagnosed as ADHD. Especially yung lack of focus. And then yung pag kuwari may mania pa yung mood disorder niya, 'di ba? So it can be high destructibility, yung pala it's ADHD, or it might be bipolar 1. And then children being diagnosed with bipolar disorders are increasing at high rates. So this is why they put the disruptive mood dysregulation disorder kasi nga the practitioners thought that it might be more prudent to look at it in another situation kasi kasi nga bakit ganon kabilis yung pagtaas ng rates ng or statistics sa mga bata with bipolar disorder. And then the depression in elderly occurs between 14% to 42% in terms of the prevalence. And it occurs usually with anxiety disorder. So yun yung na-mention ko kanina. And then in terms of the difference between the sexes, there is a less gender imbalance after 65 years of age. So nagkakaroon na ng equal prevalence, particularly in depression pag after 65 years in age na. In terms of culture, ayan, similar prevalence among US subculture, but experience of symptoms may vary. So, some cultures are more likely to express depression as somatic concern. So, there are um, cultures like that dahil especially for cultures na alam mo yung longer yung nights or yeah, yung mga places in the world na mas mahaba yung gabi kaysa sa umaga. So definitely mas iba yung presentation nila ng depressive symptoms kasi nga yung tulog nila is disrupted because of the kind of time because of the time zone that they are in. And from what they have seen in the statistics in US, it has higher prevalence among Native Americans, about 4 times the rate of the general population. Likely because of how they fare in the socioeconomic strata as well, diba? And basically the treatment of society kasi may inequality pa rin naman sa US despite of uh, the age and time that we are in. May ganun pa rin problem. And then for the causes, um, looking at the family studies, the higher risk is seen if there is a relative with mood disorder. And then relatives of a bipolar province are more likely to have unipolar depression than a uh, bipolar disorder. And then with the twin studies, concordance rate are high in identical twins, 2 to 3 times more likely to present with mood disorder than a fraternal twin of a depressed co-twin. There is also severe mood disorders that has a strong genetic contribution. Heritability rates are higher for females compared to males. So this is why um, pag tinitingnan din namin, kuwari, suspected na nga namin with depression, tinatanong namin, did anyone else in the family have depression, ganto-ganto, or nag-suicide, kasi baka mamaya yung cause ng suicide doon sa family nila is because of the depression. And then, some genetic factors confer risk for both anxiety and depression. So in terms of the neurotransmitter system, serotonin and its relation to other neurotransmitters are being looked into. So although hindi pa talaga hindi pa talaga comprehensive ano ba, up to what extent ba ang ginagawa ng mga neurotransmitter system natin, but implicated ang serotonin natin in terms of having mood disorder. So in the studies before, they have seen that mood disorders have been attributed to low levels of serotonin. Aside from that, ito yung sinasabi nila permissive hypothesis, low serotonin permits other neurotransmitter to vary more widely, thus increasing vulnerability to depression. So dahil nga mababa daw yung serotonin levels, yun, nag-i-increase ngayon yung ibang level, nag-i-increase or hindi na ba-balance out yung ibang level ng neurotransmitter. Kasi nga, remember, that serotonin regulates norepinephrine and dopamine. So, pag mababa siya, hindi niya nare-regulate tong dalawa or wala siyang capacity to do one of the functions, and that is to regulate the levels of this neurotransmitters, and this causes the person to be more vulnerable to depression unlike other people. And then in our endocrine system, it also has something to do with the development of the mood disorders. So the elevated cortisol, now remember cortisol are our stress hormone. So kung mataas ang cortisol level natin, it does not only make us very anxious, it can also affect our mood. So this is why, 'di ba, going back with our anxiety disorders, merong mga anxiety disorders na may depressive features because of this one, and vice versa. Depression with anxiety features a specifier. So, stress hormones decrease the neurogenesis in the hippocampus. So, dahil nga alerted ang ating system because of the stress, hindi ngayon nakakagawa ng bagong neurons ang ating brain sa hippocampus, and this makes the depressive state more prevalent. And this one, the sleep disturbance as well. So this is why sabi ko nga, pag tulog-tulog talaga, wala akong pake kung anong nangyayari, kasi nga a lot of people or a lot of my clients who come to me with depression, ito yung isa sa mga sinasabi nila, isa sa mga prominent nilang symptoms, yung sleep disturbance nila. Okay, so depressed patients have quicker and more intense REM sleep. So unlike other people na they go through stages of sleep before reaching the REM sleep, sila mas mabilis silang nakakapunta doon. And then they also have sleep deprivation. Ayan. Sleep deprivations may temporarily improve depressive symptoms in bipolar patients. Temporarily improve, meaning to say, hindi niya talaga yun maayos. But for sometimes, especially siguro pag napagod ka na, kasi nga pag nagmanic ka, it uses a lot of energy. So talaga makakatulog ka pag after mo na ng manic episode. Pag depressive episode ka na, makakatulog ka talaga nun. Kaya nga temporarily, tapos naka-italicize ang improve. Because it doesn't really improve the sleep per se. Okay. And then, in terms of the psychological dimension, stressful life events can trigger the mood disorder to happen. And stress is strongly related to mood disorders. So, the poorer response to treatment, ayan, mas mataas ang chances for winning, for developing mood disorder, and the longer time before remission. So, the context of life events matter. So, dito rin po pasok yung learned helplessness na sinasabi ni Seligman. Kasi nga, again, if you're someone who looks at problems like a catastrophe, ayun, catastrophizing, yun yung word, sorry, medyo nakakabulol. Pag gano'n yung tingin mo doon sa problem, definitely is going to be a stressor later on that can result to development of mood disorders. Kasi nga parang eventually, if you continue looking at the situation like that, papasok na sa utak mo na there's no way out of that situation hanggang sa ma-depress ka na, kasi nga ang iniisip mo ay wala na, ganyan ka na lang forever, or wala ka ng way to improve your situation. There are this the gene environment correlation is also seen here, wherein people who are vulnerable to stress might likely um, enter situations that will lead to more stress. So, ayun. Like, for example, mataas ang tendency niya for stress. Uh, Tapos, papasok siya sa relationship na very stressful. So, yun. Like, abusive relationship. So, yun. And the relationship between stress and bipolar is strong as well. Or, pag titingnan natin in mathematical context, um, high positive correlation ang meron tong dalawang to. Okay. So, with, as mentioned, yung learned helplessness ni Martin Seligman, isa to sa mga theory ng depression wherein, yun nga, if the person feels that they cannot control the situation that they are into anymore, it will lead to decreased attempts to improve the situation. So this is also why a lot of people who are in an abusive relationship, they tend to develop depression later on kasi nga um they look at it as lifelong situation, especially yung mga generations before na hindi hindi ganon ka open or hindi or very conservative ang tingin sa relationship, like yung mga naging clients ko before for annulment cases. So sometimes some of them would say na yun nga, kasi hindi ko naman siya pwedeng hiwalayan kasi asawa ko siya, etc., etc. So they have that kind of idea na dahil nga kasal sila doon sa partner nila, and they look at marriage as a lifelong commitment, they don't have any other way to escape that situation. So ayan, nagde-develop ngayon nung depressive symptom nila kasi nga parang ang tingin na nila, they are going to be abused forever. So, with this one, negative cognitive styles are a risk factor for depression. So, yung thinking nga na gano'n na the relationship is abusive but I'm married to this person, so therefore um, I cannot escape this type of relationship, or the abusive relationship will be part of my life. And that is if kung ayun nga mas maunang mamatay sa kanya yung asawa niya or yung partner niya. So that is a negative cognitive style. Accept ko na lang to kasi kasal kami, yung mga ganun. Okay. It also comes, or it may be because of internal attribution, like for example, negative outcomes are one's own fault. So may mga ganun din ako nakita doon sa several years ko handling annulment cases. So dahil nga minsan kasi yung nakipagtanan sila, so minsan sasabihan sila na, oh, panindigan mo yan kasi hindi nga kita pinayagang makipagrelasyon sa kanya pero ikaw lang yung mapilit. So ayun, nagkakaroon ng negative attribution doon. So kasalanan ko to, so kailangan pagtiisan ko kasi nga naman tama naman si nanay, yung mga ganun na idea. So it can also help develop or increase your risk factor in developing depression. And then there is also stable attributions wherein believing future negative outcomes will be one's fault. So again, nakikita din namin yan doon sa naman, may iba kasi na, yun, iisipin nila makipaghiwalay, pero sasabihin nila, kaso bata pa yung mga anak ko, baka mamaya, pag wala silang tatay, or pag naghiwalay kami, paging pangat yung paglaki nila, magkaroon din sila ng problema later on. So, that is also another risk factor that may cause the development of the disorder. Okay, and then aside from that, um, the global attribution wherein believing negative events will disrupt many life activities is also another attributional style that can lead to depression later on. So, we've seen that happen nitong pandemic. A lot of or there are some of my clients who would tell me na, ayun, kasi nangyari tong pandemic, so parang ang gulo-gulo ng buhay ko, ganto-ganto. Kung hindi nagkaroon ng pandemic, ano ba to? Sana na-promote na ako, or sana nakapunta na ako sa ibang bansa, ganto-ganto. So, that's global attribution. Kasi nga, the pandemic is a negative event, and that particular event had caused disruption to a lot of their life activities or life plans. So, which is true naman. However, the problem is that the pandemic is not something that we have control over. So, um, yung ganong attributional style kasi hindi siya nakakatulong in proper coping or proper resolution in order to a proper behavior or idea in order to address the current stressor. So all of these three domains contribute to the sense of hopelessness for the person. Okay. And then we also have the cognitive theory in explaining the cause of the disorder. So the first one is the negative coping style. The depressed person engage in cognitive errors, tendency to interpret life events negatively. So just like what I mentioned doon sa mga cases namin for annulment na yun nga, dahil nakipagtanan ako dito, nagpakasal kami, so I have to parang kailangan niyang ano ba to? Pagtiisan yung ganong type ng relationship or lifestyle as well. And then, types of cognitive errors, we have the arbitrary inference, overemphasize the negative aspect of a mixed situation. So, like with the pandemic, so, of course, everyone's lives were disrupted during that time. Pero, aside from the pandemic, kasi there are other factors that cause us to be in or to respond negatively. Pero parang ina-attribute lang natin in the pandemic or yung parang side effects ng pandemic. So, arbitrary inference. And then, overgeneralization. So, negatives apply to all situations. So, ito yung mga sabi niya, pag ginawa ko naman yan, di naman ako tatanggapin, ganto-ganto. So, kumbaga, di pag ginagawa, there's already a sense of hopelessness and helplessness. And it's not improving the situation of the person. At the same time, it's also causing the person to have or to develop depressed feelings. Okay, next is the cognitive errors and the depressive cognitive triad. So, the tendency to think negatively about oneself, like, I'm way too shy, hindi ko yan kaya, di ba yung mga ganon. Think negatively about the world. So, people, like, for example, sabi, the people like outgoing and friendly or personable people. So, people like me who's not personable or who's more introverted are not really is not really going to get any attention. So that's the the negative thinking about the world. And then negative thinking about the future. Yan. I'll never find a life partner. So yan. That's a cognitive triad. So, yan. So let's attribute it to sa mga cases ko ng annulment na nagkaroon ng depression or nag-develop ng depressive features or symptoms. So, first one, yun nga, wala na magkakagusto sa akin kasi nga I was already married, tas abuse pa. And then people wouldn't like me kasi nakipaghiwalay ako sa asawa ko. They wouldn't like a separadang babae or separadang tao. And then ito. So hindi na magiging magandang buhay ko kasi I'm a divorcee or I'm annulled with my husband or wife, and then yung mga anak ko hindi na maganda tingin sa akin. So that's a depressive cognitive triad. Okay. Now, pupunta tayo dito. Di ba? Puro mga annulment cases yung example ko. This is because what they have seen is that marital dissatisfaction is strongly related with depression. So, medyo mataas ang association nitong dalawang to. So, the higher the marital dissatisfaction, the higher the tendency to develop depression as well. So, I'm not saying that being married is bad or whatsoever. It's just so happen na ganun yung nakita nila in the studies. And what they have seen is that this particular relation is higher in males than females. So I cannot say anything about this anymore kasi nga I have not really seen the studies about it. Pero nga kasi if the relationship is poor, definitely mataas ang marital dissatisfaction, and it will lead to development of depression at some point. In terms of social support, the extent of social support is related to depression. So ito rin yung mga sinasabi namin na when a client comes to us for help, ito yung isa ko sa mga tinatanong kagad sino social support mo? Kasi if there's very poor social support sa family niya or even sa friends, wala siyang friends na ma-identify na susuportahan siya sa kanyang pinagdadaanan at sa kanyang ginagawa, the intervention will not progress quickly, and the prognosis is not going to be good that as well. So same with the depression, pag mababa yung social support system mo, mataas din ang tendency na magde-develop ka ng depression kasi nga it emphasizes more the feeling of helplessness and hopelessness kasi nga feeling mo mag-isa ka lang, wala kang kasama sa mundo, di ba? Parang mag-isa mong binubuhat yung burden mo. So, it's not really going to help if you have depression and your social support is very poor. Now, the studies have also found out that the lack of social support predicts late onset depression. So, with adults, nakikita din yan sa kanila, especially yung mga senior, yung mga nasa 65 years old and above, pag nakita, kasi nga, again, based on statistics, hindi naman sila masyado nagde-develop ng depression or mababa ang prevalence sa kanila ng depression. However, for those who have developed depression at that age, tinitingnan namin ano ba yung social support nila. And then nakikita namin, ayun, pinabayaan na ng anak, tapos yung mga anak, minsan, parang once in a blue moon lang tumawag, hindi dumadalaw, yung mga ganon. So, mas mataas yung tendency na ma-develop nila yung depression. And then, as kabaligtaran nito, substantial support system predicts recovery from depression. Now, the greater your social support, the higher your chances of recovering from depression. Which is, again, true for any form of disorder. Kung wala kang support from the people around you, it's really difficult to recover. Even yung mga lagnat lang, 'di ba? Napapansin natin 'yun. Parang ang tagal mong gumaling pag walang nag-aalaga sa iyo. Kasi nga that uh, people are social animals. We are not born to be alone. All right. So, let's talk about the gender differences in mood disorders. So, for every 10 cases, 7 out of those cases are women for major depressive disorder. And it's also the same for anxiety disorder. Mas mataas din ang number ng mga babae na may anxiety disorder than with males. Whereas in terms of the bipolar disorder, halos balance lang ang ratio ng male to female prevalence. Okay. Yan. So, kung makikita nyo, ayan, in any part of the country, there's a big gender disparity between males and females in terms of the depressive diagnosis. So, again, it's hindi hindi pa conclusive or hindi pa sure if it's because the male underreports the condition or may stereotype na nagaganap even sa professional field na mas mataas ang chances na i-diagnose with depression ang babae kaysa sa lalaki. Kasi nga, again, we have this idea that women are more emotional than men, right? So, may mga ganong factors din kasi. So, hopefully in the near future, this will be studied more extensively para mas makita if it's really the disparity, or if the disparity between genders is caused by biological differences or if it's because of the social perception of the gender roles between male and female. Okay. Ayan. So, ito ang isasabi ko kanina. Possible explanation for gender disparity. Women socialize to have stronger perception of uncontrollability. Diba yung going back to the history of Freud attributing hysteria to females only. Oh, hindi lang kay Freud, kay ano pa, kay Hippocrates. Kasi nga, yung wandering uterus, babae lang naman na may uterus, right? So, and then the term hysterical is more attributed to women than males. And then, with parenting style, especially for patriarchal dominated cultures, like for example, Japan, South Korea, India. So those are focused on the father, wherein they still the parenting style make girls less independent, unlike with males. Hindi ko susama dito ang Philippines kasi hindi tayo ganon in terms of the parenting style. We are fortunate enough that Philippines actually is very progressive between gender equality when it comes to gender equality. Kasi there's a study recently that was done and na ang nakita sa study is mas madaming mga babae ang humahawak dito ng managerial position So, parang nakipagsabayan tayo sa mga first world countries in terms of gender equality. Okay. And then, aside from that, women are more sensitive to relationship disruption, like for example, breakup, tension in friendship. So, yung kasi yung nakikita na mas affected tayo when we go through breakup or pag nakipag-away tayo sa mga friends natin, unlike with men. And then, they also have seen that women tend to ruminate more than men. Ruminate meaning to say we tend to think about the situation, or we tend to obsess about the situation. I'm not sure if that proper term is obsess, pero ayun, parang diba, like for example, nag-break up na nga kayo, tapos iniisip mo, bakit niya ako iniwan? Eh, ano naman ako, diba? Yung mga ganon. Um, hindi, hindi pa ako nakakarinig ng uh, tao na hindi nagtanong sa akin ng ganyan, na galing ng breakup. Yung parang pagkatapos sa breakup, ayaw mo na siya sa buhay niya, tapos na yun. Laging ano, okay naman ako, diba? Bakit niya ako iniwan? Yung mga ganon-ganon. So, or minsan kahit yung away lang, sabi, tama naman 'di ba yung ano ko, yung point of view ko, bakit ganun kaya ginawa niya? Ano lang naman, sinabi ko lang naman yung dapat ko sabihin, blah blah blah. So, we tend to ruminate more than men daw. And this is the explanation for the disparity in the number or the prevalence of depressive disorder between genders. And then looking at the explanation of depression in an integrative theory, ayan, eto na tayo. The biological and psychological vulnerabilities interact with stressful life events to cause depression. So in the biological vulnerability, if we have an overactive neurobiological response to stress, so yun nga yung cortisol natin, over the top yung level ng cortisol natin. So, we are always stressed out kahit hindi naman dapat ika-stress yung sitwasyon. And then, coupled with the depressive cognitive style. So, yun. Parang iniisip mo, lagi na lang may problema, kailan ba ako mawawala ng problema? So, combination of the two, the possibility of developing the disorder is quite high. Okay, so let's look at it. Biological vulnerability to psychological vulnerability. So, stressful life event. Yan, personal loss, nakipag-break sa jowa. For mania, achievement. Yan. So, problems in interpersonal relationship and lack of social support. And then, this one will lead to kung depression, negative attribution. Pag mania, ay positive attributions naman, or sense of power, or dysfunctional attitude. And then activation of stress hormone, and then going to the mood disorder. Okay, it's very imperative, or it's very important that you understand how to explain it, kasi nga mamimigay na ako ng cases. So, kasama yung mga past disorders na pinag-usapan natin. Pwedeng yun yung ma-assign sa inyo. Hindi lang ako makatsyempo before the midterms, kasi nga biglang, di ba, nagkaroon PAP, yung mental health week, di ba, and then the midterms week, hindi ko na siya naisingit. Okay. Now, for the treatment of the disorder, so we have, of course, for the medication, we have the antidepressant. So the antidepressants, usually, nandyan yung SSRI, yung tricyclic antidepressant, or the monoamine oxidase inhibitor, or the MOI. And then the mixed reuptake inhibitors, so it's either pwedeng serotonin or norepinephrine reuptake inhibitors. Kasi nga, depending on anong unbalanced na level ng serotonin. Yun yung ibibigay sa yung inhibitor. And then, approximately, only about 50% of the patients benefit from medication. And then, 25% achieve normal functioning, meaning to say, nagagawa na nila yung mga dapat nilang gawin when they take medication. So, hindi pa rin siya 100%, and the statistics tells us something, 'di ba? Kasi ibig sabihin hindi siya talaga effective na medication lang. So, you have to put something else with the medication in order for the patient or the client to really cope with the disorder. Okay. Now, the SSRIs, ayan, it blocks the reuptake of serotonin. So, more serotonin is available in the brain. So, the Prozac or fluoxetine is the most popular SSRI. So, remember yung pinanood natin na video, yung reuptake kasi yung bumabalik ulit si neurotransmitter palabas doon uh, sa brain cell para so pag ang reuptake blocker, hindi niya palalabas si serotonin para nga andun lang siya sa loob ng neuron, and then gawin niya yung dapat niyang gawin. However, ang problema kay SSRIs, what they found out is mataas yung risk ng suicide for teenagers, for people who are taking this type of medication. And then, aside from that, there are negative side effects na ayaw ng mga pasyente, of course. Sino ba may gusto ng ganong side effect? Although there were some evidence that SSRI used during pregnancy lowered risk for birth complication. Okay. Now, the tricyclic antidepressants naman, ito yung mga usual. Tofranil and Elavil. Okay. But, so far, hindi pa naaaral mabuti yung mechanisms nitong antidepressants na to. But, they do block the reuptake of norepinephrine and other neurotransmitters. Possibly the dopamine, kasi nga included siya sa implicated na neurotransmitter kanina, yung diniscuss natin. Okay. Now, negative side effects na to, drowsiness. So, may mga clients ako na ganito yung minimension sa akin. Sabi, ayoko na mag antidepressant kasi yung binigay sa akin ng doktor ko, inaantok ako and then tumataba ako. So, sinasabi ko sa kanya, siguro pag-usapan nyo yung side effects and how you feel about that para mabigyan ka ng ibang gamot. Kasi, on my part, I cannot help you with I cannot tell you na you discontinue that kasi blah 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 because I don't have the right to do that, 'di ba? So, dahil nga may ganun siyang disorder, dahil nga may ganun siyang effects, ayan, maraming mga pasyente na dinidiscontinue yung medications na yon. And aside from that, kaya rin hindi rin siya masyadong pinaprescribe ng mga doktor kasi nga it is lethal in excessive dosage. So, but here in the Philippines, ang ginagawa na dosage ng mga doktor, paunti-unti lang para bumaba nga yung yung possibility na mag-overdose sila. Okay. Now, we also have the mixed reuptake inhibitors. So, this one, the best known medication for this is Effexor or venlafaxine. Okay, and this one blocks the reuptake of norepinephrine and serotonin. And unlike with SSRIs, it has um, it has fewer side effects. Now, the next one is the monoamine oxidase. Uh, this one, it blocks this particular component, and the the enzyme breaks down serotonin or the norepinephrine. Ang nakita nila with this inhibitor is that it is effective as the tricyclics, but it has fewer side effects. However, ayan, hindi siya pwedeng i-combine with certain foods. Like, for example, beer, red wine, cheese, hindi siya pwedeng i-combine or hindi ka pwedeng mag-take ng mga ganito pag nagtitake ka ng gantong gamot. So, a lot of patients does not like that restriction. And is this also, this cannot be also taken with cold medicine. Like, for example, Nafarine, the medicine that I'm taking, or Neosep, hindi pwede. Kasi nakakaantok yung mga yun eh. Uh, so, it cannot, ano bang tawag doon? I forgot the chemical term for that. Pero, hindi siya pwedeng i-combine together. Otherwise, um, there will be, of course, very grave consequences. Okay, now there are also um, other types of treatment for mood disorder, like the use of lithium. So lithium carbonate, this is the common salt that we have, and this is usually the treatment of choice for bipolar disorder. So this is considered as a mood stabilizer because it treats both the depressive and the manic symptoms. However, lithium carbonate is toxic in large amounts. So this is why um, the doctors have to monitor carefully the dosage. Although in terms of its efficacy, it's only effective, or it's found to be effective about 50% of the patients. And in terms of the studies, hindi pa nila nakikita talaga what makes lithium work, or bakit mataas ang efficacy niya. Kasi 50% is quite high number for a treatment. And then we also use the electroconvulsive therapy. Ito yung nag-induce ng shock or electricity sa brain. Electrical current. So, the electrical current applied to the brain results to temporary seizures to the patient. And usually about 6 to 10 outpatient treatments are required for it to be effective, or para makita mo na yung effect niya. So, side effects niya, ayan, short-term memory loss, which is usually restored naman after some time. But then, there are some patients who suffered long-term memory loss. So, medyo yun yung problema dito. Now, the mechanism for this one isn't clear, but as we have discussed in the previous chapters, particularly the history, the first the first and the second chapter, the electric current is going to be applied to a specific part of the brain. Hindi dun sa brain mismo, 'di ba? Lalagyan na ng parang diodes yung sa ulo na parang not mako-connect, or mararamdaman na rin sa brain. And this and what they have seen so far is, 'di ba, parang nakiklear yung utak do sa history, yung historical accounts when this was first discovered as a possible treatment for the psychological disorders. Next is the transcranial magnetic stimulation. This one uses magnet to generate a precise localized electromagnetic pulse. So, Unlike with the ECT, this one has fewer side effects, but then the client tends to get emotional, occasional headaches at times. And then, in terms of its efficacy, it seemed to be less effective uh, than ECT for medication-resistant depression. So, pag sinabi natin medication-resistant depression, ito yung mga depression na hindi talaga nag improve kahit anong gamot na ibigay. May mga ganong condition. So, dahil nga mas mababa ang efficacy niya sa ECT, ayan, kinakombine siya at times with medication. And then for the psychological treatment, cognitive behavior therapy is still used. Actually, maraming gamit si CBT. Um, it's quite useful for a lot of disorders. So, if the disorder is coming from the cognitive errors or negative attributional style of the patient or learned helplessness of the patient, this particular approach will be very helpful. Ayan. Also includes behavioral components including behavioral activation, scheduling valued activities. So like what I did with one of my clients, naka-experience siya ng depression. So sabi niya, hindi ko na nga nagagawa yung gusto ko, like painting, reading, ganto. Kasi nga daw, wala daw siyang, motivation to do it. So ni-reframe ko, I use CBT for the case. Sabi ko sa kanya, you don't have to look for motivation to do it. Sometimes just starting the activity itself is enough to activate your motivation. Kasi nga, ang thinking natin usually is we have to be motivated to do action. Pero, research had been telling us that we have to do action first before motivation to follow. So, ganun talaga siya. So, yan. So, ang ginawa namin doon, para makombat niya yung kanyang fatigue, in-schedule namin na per week, kung ayaw mong ma-pressure sa schedule per se, just make it to a point na per week, magpe-painting ka or magde-drawing ka, kahit anong activity na related sa painting or drawing. It doesn't have to be done on a specific schedule kasi ayaw niya rin na na-stress siya with following schedules And then we also have interpersonal psychotherapy if the problem itself is more on the relationship, like for example yun, magkita kaming kinausap before, annulment case, although hindi namin talaga trabaho yung pagka-counseling or psychotherapy sa kanila, we did, however, tried our best to improve the relationship with with the ano ba to? With the children. Kasi, parang nagkakaroon nga siya ng depression dahil nga nung nag-decide na siyang makipaghiwalay, feeling niya nagagalit sa kanya mga anak niya kasi, ayan, makipaghiwalay nga siya dun sa asawa niya. Whereas, nung in-interview naman namin yung anak, sabi niya, nagagalit kami kasi hindi niya sinabi na ganun yung pinagdaanan niya. So, yun. So, we focus more on the interpersonal relationship for that particular case. And then, prevention, if the person is or has the probability of developing the depressive disorder based doon sa nakikita nyo, ayan, preemptive psychosocial care for people at risk. Like, for example, yung stress na siya or burnout na siya kasi mataas ang chances pag ganun sobrang stress ka or burned out ka na, mas mataas ang chances man magde-develop ka ng disorders. And what they have seen for this type of treatment is that it has longer lasting effectiveness or efficacy than medication. Okay, in terms of relapse, research on relapse prevention is relatively less common So, hindi, parang wala pa masyadong nagagawa in preventing relapse per se. Kasi nga, again, uh, unfortunately, may mga ganong ugali talaga yung mga pasyente na parang hindi sila pupunta sa professional unless na talagang full-blown na yung symptoms nila. And to prevent relapse, both psychosocial and pharmacological treatments have to be used. And what they have seen in studies is that the psychosocial interventions are generally more effective at preventing relapse. Okay. Now, for treatments for the bipolar, ayan, usually it's lithium. That's the first line of the defense. Usually, yung ginagamit nila. And psychotherapy is helpful for management of problems like interpersonal, occupational problems that comes with the bipolar disorder. Family therapy can be also helpful, especially since lalo na kung bipolar 1, hindi kasi sila minsan naintindihan ng mga kamag-anak nila bakit sila nagaganon na sobrang high or hyper ng isang araw, then the next a few days sobrang down naman niya. So, syempre, if you're living with a person with this level of fluctuations in mood, medyo mahirap talaga mag-adjust. So, definitely it's going to cause problems. Okay, so let's move on to the third part. Again, you may pause the recording if you want to stretch out, drink something, uh, not something, but drink water or coffee. Baka mamaya kung ano nang inumin nyo. Or to have a snack first before listening again to the discussion and taking down notes. Alright. So, moving on to suicide. Facts and statistics. Suicide actually, in the US, this is the 11th cause of death. Worldwide, this is already acknowledged by the World Health Organization as a health problem, emerging health problem in the different parts of the world. So, I didn't get the actual numbers here in the Philippines, but definitely given the anxiety and the depression experience over the last 2 years because of the pandemic, definitely tumaas yung number for suicide. And again, forgive me for this one because the book is based on America, so the statistics that we have are more on the American statistics. However, in our case, the World Health Organization have listed it the 2019 statistics. We have 2.6 case of suicide or completed suicide rate here in the Philippines for every 1,000 population. So it seems to be a small number of suicide cases here, but syempre dahil we're talking about life, kahit isa lang yan, it's still not a good number. Okay. So in US, it's more common for white and Native Americans, and this is because ang nakita kasi sa studies or nababasa ko with the studies that they have, it's because they tend to have lower number of social support. With the Native Americans naman kasi more on very conservative pa rin yung belief ng mga matatanda sa kanila. So that's why in terms of receiving support, it's not really felt that much by other Native American people. Excuse. Okay, suicide is particularly prevalent in young adults. So this is not only in US but also in other countries, particularly Asian countries like Singapore, Japan, and South Korea. So medyo mataas ang number ng suicide doon sa mga teenagers. So this is the third leading cause of death among teenagers and the second leading cause of death in college students. So again, the statistics is in 2018, wala pang bago. So far, nung nagbigay ako ng talk about suicide, it's the recent statistics is only at 2019. Wala pang 2021, 2020, wala pa. 12% of the college students, they have found out, based on statistics, would be considering to commit suicide in a given year. And in terms of gender differences, there are more males who have completed more suicide than females. So, mas mataas ang number ng mga males na nagsusuicide kaysa sa babae. And by the way, we don't call it successful suicide, we call it completed. Kasi we don't consider success in suicides. Alright? So, just like with prognosis, meron tayong specific term that we use for reporting prognosis. However, in terms of attempts, mas mataas ang attempt ng suicide ng babae kaysa sa lalaki. And the disparity is attributed due to males using more lethal methods like gunshot. Kasi mga babae ang ginagawa nila is overdose sa gamot or overdose sa gamot or yung magbibigti. So, minsan kasi it fails those type of method, whereas with males, most of the cases would be gunshot wounds, and they would do it in the lethal parts of the body, yung talagang walang takas. So they would shoot themselves on the head or through their mouth. So exception to this statistics is the population in China. Mas mataas ang suicide rate ng mga babae kaysa sa lalaki. So ang nakikita nila dito is that it might reflect cultural acceptability, wherein suicide is seen to be more of an honorable solution to problems than than living or continue to live on. I think this is the case for yung mga parang thought sa Confucian philosophy. I remember one period drama that I've seen, yung parang na-chismis lang siya na nakipagrelasyon kasi parang nakidnap siya ng mga I forgot kung anong tribe yun eh. Pero it's based on historical facts. Nakidnap siya ng mga tribo na yon, so parang nawala siya for a week. Nakabalik siya ng buhay doon sa village nila, pero dahil nga babae siya at ang kumidnap sa kanya mga lalaki, parang pinagchismisan siya na parang nagkarelasyon siya doon sa mga kumidnap sa kanya, kaya siya binuhay. Kasi parang siya lang yata yung nakatakas doon sa kidnappers. And then, dahil doon, parang she brought shame to the family, especially the family of her husband. So, sinabihan siya ng mother-in-law niya na dapat hindi ka na bumalik or sana namatay ka na lang doon. Otherwise, we would not feel dishonor because of what happened. So, ganon ang thinking kasi nila at that time. Now, in terms of the risk factors, ayan, tumataas ang risk factor ng isang tao in committing suicide if there is a history of suicide in the family. Also, if the person has low serotonin levels, mas nakikita nila yon sa mga taong um, nag-attempt or who had completed suicide. And then, the pre-existence of psychological disorder, particularly, yun nga, yung uh, depression, bipolar disorders, or post-traumatic stress disorder are also some of the disorders that has a high risk factor for suicide. Also, alcohol use and abuse, mataas din yan. Ang stressful life event, especially humiliation. There are yung anak ni the late Senator Miriam Santiago. Her son committed suicide. I think after after failing a subject. So because it was caused by stress kasi nga syempre if your mom is Miriam Santiago, 'di ba? Na parang in terms of the achievements and accolades, parang and then ikaw na anak niya nag-fail ka, 'di ba? So parang the son was very um disappointed in himself and very ashamed. So yun, nag-commit na siya ng suicide. Past suicidal behavior or attempts are also seen as a risk factor, and also plans and access to lethal methods are also risk factors. So I'm sorry for that kasi pag matagal na ako nagsasalita talagang nagaan na yung aking uh, lalamunan. So this is why yung mga sinasabi sa atin na baka magpakamatay na nga lang ako. That is already a plan. It's already a plan, and we don't take it lightly. We take it seriously. So and also an access to lethal methods. One of the clients that went to me na nakitaan nga siya ng suicide ideations. So parang na red flag siya, or sinabihan ako na red flag to for suicide. Yun, I have to make sure na wala na yung mga knife niya sa bahay, yung scissors niya, and then we have to be in contact doon sa contact person niya to check the client out from time to time, na at random times kailangan i-check niya kasi nga may risk factor na sa may risk factor na sa pag-commit ng suicide. Okay. Okay. So, kung makikita natin ito yung mga predisposing risk factors, genetic or family history, biological factors like perinatal factors, personality traits like impulsivity, psychiatric diagnosis, environmental factors or suicide exposure, like for example may friend siya na nag-suicide or may kamag-anak siya na nag-suicide, so those are also risk factors. So it all leads to the vulnerability to suicidal behavior. And then in terms of yung protective factors, cognitive flexibility, strong social support, lack of precipitating events, no losses, hopefulness, treatment of psychiatric disorder, treatment of personality disorder. Those are all protective factors in this case. Precipitating factors, what is the available method and the level of threshold, hanggang saan niya kakayanin yung mga stressor niya. And then the humiliating precipitating life event. So, pag di niya kaya, yan, it will lead to the suicidal behavior or the completion of suicide itself. Okay. Um, there are some research that shows that a person is more likely to commit suicide after hearing about someone else committing suicide. And there are accounts like that na sa isang class, parang several of the students committed suicide because of after learning that one of the classmates committed suicide. So it's not that the suicide is contagious per se, but rather parang parang mas pinatataas niya kasi yung risk ng taong uh, nag-iisip na rin mag-suicide. Kasi parang nasisip mo, kung kinaya niya nga, ba't di ko gagawin? 'Di ba? Parang ganun din kasi yung thinking mo nun pag gagawin mo yun. Of course, we cannot confirm this assumption because these people have completed suicide, so we don't have anyone to ask bakit nila yung ginawa. Although those who were not able to complete their suicide or just attempted, ang sabi nga nila is, kasi nakita namin na nagawa naman nila. So why not us? And then, media accounts may worsen the problem by sensationalizing or romanticizing suicide. So, ayun, yung may mga ganong story din na, alam mo yun, nakakabwisit siya, na parang, kasi nawala yung jowa niya, namatay sa cancer, so papakamatay na rin siya. So, it doesn't really help. Tapos makakita ka pa ng mga comments na, at up until the end, very loyal siya sa ano niya, sa loved one niya. It's not helping with the situation because we're talking about life here. So, suicide shouldn't be romanticized because, at the end of the day, we are parang helpers. We are mental health helpers who should or who would give importance to life. And then, of course, describing lethal methods of committing suicide can also worsen the problem of suicide contagion. Ayaw gumalaw. Ano nangyari? Alright, so suicide prevention in professional mental health. The clinician does risk assessment, so the ideations, plans, intent, means, etc. Tinatanong namin yon. And uh, ano ba to? And this is what happened with me last week. I had a suicide case na binantayan namin. I was not able to immediately talk with the client because of my schedule. Masyadong jam-pack yung schedule ko nun. Although the doctor in the workplace and then my supervisor who's also a psychologist already have an idea na may plans nga for suicide yung client ko. It just so happens na parang nag-inter-rater reliability kami. The problem was that the client was was highly distrustful. So, ayaw niya magsalita dun sa boss ko. Ayaw niya rin magsabi masyado dun sa doktor. And even when I was trying to get the client to talk with me, ayaw niya rin magsalita sa akin. So, pretty much we were left, parang clueless. Ano bang nangyayari sa kanya? However, nung bigla siyang nag-message sa akin, ayun, hindi nila ako naintindihan. Akala nila nagdadrama lang ako. And then, suddenly may nag-pop out doon sa preview ng message niya. Pag uwi ko, magpapakamatay na ako. So, I already messaged my boss and the doctor na nag-handle din ng case niya in order for us to do or to make an action plan um, to prevent the suicide or the suicidal behavior from happening. So, um, yun yung ginawa namin. We did a safety plan. However, in this case, it was really tough to do kasi hindi namin malaman sinong tatawagan kasi nga ayaw niya magsalita. Tinatanong ko siya kung sino ba yung jowa niya, and then can I get the contact details of the significant other para makontak ko din, and so that I would also have an idea what's causing the problem. And then, in terms of strategies for coping with the suicidal thoughts, hindi ko na nagawa yung part na yon kasi nga na-alert na kami nung biglang nag-pop out yung message na yon sa application ko. So, we had to do something about it kasi nga tatlo na kaming naka-detect eh. So, yan. So, in some cases, sign no suicide contract. So, may mga ibang ganon na especially if they see that the client is very conscientious tas may suicide plans. So, yan. Minsan, ang ginagawa ng ibang mental health professional, pinagsasign nila ng no suicide contract. That is only if it's applicable for the client. Hindi kasi siya applicable for everyone. And then, preventive program for at-risk groups. So, pwede yun. You can use CBT to reduce the suicide risk. And this is very important to remove access to lethal methods. So, yun nga yung mention ko kanina, yung isang client ko na nag-walk-in sa akin. Meron na siya talagang therapist, and the therapist advised her to put away all of her sharp things, yung knife niya, yung kanyang gunting. So, ang ginagawa niya ngayon tuloy is nag-eat out na lang siya dahil hindi nga siya makapagluto sa bahay. Okay. Now, with suicide prevention, again, if you think someone is at risk, um, we have to talk to them. Yun nga yung isa sa mga kailangan mong unahin in order to be ensured that they're getting the support that they needed. However, hindi sa lahat ng pagkakataon magsasalita sila, just like what happened in my recent case. So, with this one, alisin natin sa isip natin na talking about suicide can make them uh, can make the risk higher. So it's not like that. Actually, talking about suicide can help them vent on what they are feeling at that moment. Kaya nila kino-contemplate ang suicide. Okay. In contrast, the risk of not providing support to someone in need is huge. So, hindi tayo, as someone who's in the discipline, hindi tayo dapat mag-turn ng blind eye on this one. Na parang sabihin, nagdadrama lang yan. Katulad nga nung nangyari dun sa client ko. Feeling ko, yun yung isa sa mga rason kung bakit ang hirap makuha ng trust niya. Kasi nga, the people around that client who was supposed to be trusted, ay hindi pala trustworthy. So, kaya pagdating sa amin, ayun, hindi na namin mag-gain yung trust niya. Hindi kami nakagawa ng maayos na safety plan for that client. But no worries, the client is safe naman, safe and sound, na-prevent naman namin in time yung kanyang balak. Okay, now this one is the suicide support for US. We also have our own suicide support. I did share the crisis hotline last sem. I'm not sure if it's still with you guys. If not, you can ask me naman for the link for that. I will be glad to share it para may iba kayong pwedeng tawagan or pwedeng pag-referan ng mga kakilala nyo na may suicide risk. Okay. So, nasa last slide na tayo. Okay. So, summary of mood disorders. So, all mood disorders share gross deviations in mood, and they have common biological and psychological vulnerability. Unlike what was believed before, it occurs in children, adults, as well as the elderly. Okay. Now, the onset, the maintenance, and treatment of the disorder are affected by, first off, the stressful life events, the social support, as well as the differential response to medications. So, yan. Okay. So that's the it. That's it for the discussion of this particular chapter. Again, you can take it. You can chunk this chapter naman if you feel too overwhelmed with the long discussion or the long recording. But definitely, you have to take the pre-test. Hindi ko na siya ipa-part 1, part 2. Isang pre-test na lang tayo. Kasi konti lang naman yung kinover niya na disorders. Yun lang, mahaba lang talaga sa mga specifiers and other information. Okay, so pre-test for this particular chapter will be I'm sure you have access that kasi before accessing this recording, kailangan tapos nyo na yon. Okay, and then please ready your questions and your clarifications during the synchronous class. So, thank you guys. I'll see you on the synchronous classes. Bye guys.